cardiovascular risk estimation among residents of a rural setting in Bayelsa State, Nigeria. So you can see the outline. I'll go through the introduction, research questions, methodology, results, limitations, study limitations, conclusion, and references. So in the introduction, cardiovascular diseases are a leading cause of death worldwide. There's a rising prevalence of cardiovascular diseases in Nigeria, including rural communities. Before now, we have more of cardiovascular diseases in the urban areas, but we've been noticing a rising prevalence also in the rural communities. So this present study assessed the total cardiovascular risk among 2 rural communities in Bayelsa State, South Nigeria, using the World Health Organization / International Hypertension Society prediction charts for assessment of total cardiovascular risk. Excuse me. So the goal of this study was to assess total cardiovascular risk among 2 rural communities in Bayelsa State, South Nigeria, with a view of identifying patients that may be asymptomatic, but at different levels of risk of cardiovascular disease events, such as stroke, myocardial infarction, using the WHO/ISH risk prediction chart. And our rationale was that total cardiovascular risk assessment is more holistic in assessing for the risks of cardiovascular events than assessing each cardiovascular risk factor separately as separate entities in predicting cardiovascular events. Also, treatment strategies that are based on the assessment of total cardiovascular risk would offer considerable financial savings compared to treating each risk factor as a single entity. I'm sure many of us have heard about poly pills, where there's a combination of a diuretic, a statin, aspirin, ACI, to either prevent cardiovascular events in people at high risk of it, or to prevent a reoccurrence for those that have had. So that's why it's better to holistically assess the patient rather than using just single entities. Our research questions were: are the WHO/ISH risk prediction charts useful in stratifying the total cardiovascular risk of persons in low resource settings, such as the setting I was, which was a rural setting? What is the proportion of persons in low, intermediate, or high total cardiovascular risk strata in these rural areas? And are there a significant proportions of persons in rural areas with high cardiovascular risk status? Our methodology was a descriptive cross-sectional study that estimated the population total cardiovascular risk in 2 rural communities in Bayelsa State using the WHO/ISH risk prediction charts. Our study population were adults aged greater than or equal to 40 years in 264 randomly selected households in these 2 rural communities in Bayelsa State. Our sampling technique was simple random sampling as balloting to select the wards. We have 15 wards in Bayelsa State, 6 are urban, while 9 are urban and 6 are rural. So we use simple random balloting, sampling balloting to select those wards. And then the communities in each of these wards, we now use the same method again to select these 2 communities. And then to select the households, we use systematic random sampling to select the households in these communities. Our study instrument was an interviewer-administered questionnaire that was developed by the researchers using the WHO stepwise approach to surveillance guidelines. We pre-tested it and validated the instrument. The information collected after informed consent were gender, age, dietary intake, physical activity, tobacco, alcohol use, systolic and diastolic blood pressures, and the presence or absence of diabetes mellitus. And then physical examination included height and weight for body mass index, waist circumference, and blood pressure using standard protocols. Our samples, blood samples was for random blood sugar. We use a glucometer. Then definitions, body mass index, that's weight in kilograms divided by height in meters squared. Obesity was defined at body mass index of greater than or equal to 30 kilograms per meter squared, while body mass indexes of less than 18.5 kilograms per meter squared, or 18.5 and 18.5 to 24.9 and 25 to 29.9 kg per meter squared were classified as underweight, normal, and overweight, respectively. And then abdominal obesity, we use a waist circumference cutoff of 94 cm for men and 80 cm for women. This cutoff is the European cutoff, which has been used which is said to be useful, especially for Africans, to describe abdominal obesity. Then diabetes and impaired glucose tolerance, random blood sugar of greater than or equal to 11.1 and greater than or equal to 7.8 millimoles per liter, respectively, or a prior diagnosis of diabetes with use of insulin or hypoglycemic drugs. And then a sedentary lifestyle, less than 30 to 45 minutes of brisk walking for up to 3 to 5 times a week. Excuse me, please. Excuse me, sorry, I was sneezing. So for our definitions, hypertension was defined as a systolic blood pressure greater than or equal to 140 millimeters of mercury, and diastolic blood pressure greater than or equal to 90 millimeters of mercury, or on antihypertensives. Then significant alcohol intake was defined as 21 units for men, greater than or equal to 21 units for men, and greater than or equal to 40 units for women. Total cardiovascular risk is defined as the probability of an individual experiencing a cardiovascular disease event, such as a stroke or acute myocardial infarction over a time period, for example, 10 years. And the risk categories for 10-year total risk of fatal or non-fatal cardiovascular events include low risk, less than 10%, moderate risk, 10% to less than 20%, high risk, 20% to less than 30%, and very high risk, greater than or equal to 30%. And this is just the chart, the WHO ISH risk prediction chart for Africa did, as there are different categories. We use the chart that did not require us to use cholesterol. There are charts where where the variables include cholesterol, and there are charts where it does not include cholesterol. But it's been found that both the charts that include cholesterol and the ones that don't include cholesterol, they both more or less, there's no difference in the prediction of cardiovascular events. So we use a chart that included the variables of gender, age, systolic blood pressure, smoking status, presence or absence of diabetes mellitus, that was specifically formulated or specifically for our region in Africa. And then our data analysis, continuous variables were summarized as mean, standard deviation, and range, while categorical variables were presented as frequencies and proportions. And the proportion of participants in the different cardiovascular risk categories was obtained, and relationship of social, demographic, clinical, and medical factors were explored using the chi-square test of proportions. Our level of significance was set at p-value less than 0.05. Now, results of the 264 participants, we originally actually had 293 eligible persons, but some of them eventually did not consent to continue to participate in the study, and then some also, about 10, altogether 90% of those who were eligible were those that eventually completed the study. That's 264. And then the majority of them were men, 70.1%, and married. Over 90% were married. The mean age was 50.9 plus minus 8.1 years, so they were middle age. Most participants were overweight. Over half of them were overweight. Almost every one of them, 97% of them, add salt to food on the table. And we know this is a cardiovascular risk, adding of salt to food on the table. Lead a sedentary life. Over 3/4 of them do not engage in brisk walking for 30 to 45 minutes, 3 to 5 times a week. And greater than 1/3 of them were already known hypertensive patients. Now, using the WHO/ISH risk prediction charts for Africa, 90% and 10% of the study participants had low and moderate risks of cardiovascular events, respectively, in cardiovascular events in 10 years, respectively. And then as the age of the participants increased, the 10-year risks of a cardiovascular event also increased. You can see the chi-square value and the p-value. And then history of hypertension and smoking were significantly related to the level of 10-year cardiovascular risks event. Cardiovascular events risks. Sex did not show any significant relationship. So our study limitations, the use of just 2 blood pressure readings taken at one sitting may have affected the prevalence of hypertension in this population. And then the lack of gender differences, like I said, there was no significant difference with sex, may have been influenced by the gender skew towards male preponderance, because we had more males, over 70% were males. So that may have been why we couldn't demonstrate gender differences. And then also, we didn't assess the income of the households. And we know that low socioeconomic status is also a risk factor for cardiovascular disease events. So this may have led to an underestimation of the 10-year rate of cardiovascular disease events. So in conclusion, there was a high prevalence of several cardiovascular risk factors such as hypertension, diabetes, smoking, obesity, sedentary lifestyle in this rural population. Although that 10-year rates of cardiovascular events is still low, we didn't have anyone in the high rates or very high rates. We had 90% of them in low rates and then 10% in moderate rates. Cardiovascular disease in rural communities require awareness, monitoring, and an integrated approach to their prevention, detection, and treatment. These are some of the references. Thank you very much for listening. So I don't know if there are any questions.